dangerous TSB level are rare. This is fortunately because of the dangerous and significant complications of the extreme level of the jaundice. So the incidence, it will be just as 1 in 700 if the TSB is extremely high, more than 25 milligram per deciliter, and it will be as low as 1 in 10,000 if it is more than 30 milligram per deciliter. This is very important because such high levels can cause injury to the brain, to the basal ganglia, and to the brain stem that called kernicterus. And all our work or our job and concern and focusing is to prevent the development of this significant and irreversible damage called the kernicterus. We will know it and why it happened. But before going into the details of the jaundice, we have to know the normal physiology of the metabolism in the body. That means the normal metabolism. Firstly, from where the bilirubin is coming. I think you know that most of the bilirubin, up to 90%, is derived from heme degradation. And the remaining is coming from the non-heme sources like myoglobin. So as you know, as you see here, it means it is a waste product of hemoglobin hemolysis or degradation. But these waste products have a beneficial effect, especially in newborn, because it is regarded as a potent antioxidant that protect the normal newborn who is deficient in antioxidants. Normal antioxidants like vitamin E, catalase enzyme, superoxide dismutase. The antioxidant materials or factors protect the baby from oxygen toxicity in the first days of life. And because of deficiency in this, so the high level of bilirubin, it may protect the baby as a potential antioxidant. But of course, the level of bilirubin should be within the normal physiologic range, not more than this, to exceeding the level that may cause harmful effect on the baby. So as we say, it comes from hemoglobin degradation. So if we have a 1 gram of hemoglobin is completely hemolyzed, so it will yield about 34 milligram of bilirubin. Now, we will take the metabolism of the bilirubin from the point of its synthesis to the point of its excretion outside of the body. Firstly, the bilirubin is produced from this is the first step, which is the production of the bilirubin. It comes from breakdown, as we say, of the heme. That means the molecule of iron, protoporphyrin. This happened in the reticuloendothelial system and bone marrow. So it could be happen in spleen and macrophage. Of course, the heme is cleaved or it's dissociated to give us the iron. The iron will be reutilized in production of new RBC or new hemoglobin, and carbon monoxide, which is exhaled outside of the body, and we have diverted. This process happened under the presence of enzyme called heme oxygenase. We are still inside the spleen or inside the reticuloendothelial system. So this biliverdin will be converted to unconjugated bilirubin under the presence of enzyme called biliverdin reductase. Now the unconjugated bilirubin, which is fat-soluble, free, which is the toxic shape of bilirubin that may cause the harmful effect to the brain. Here, now it is ready to go inside the circulation. It will be combined to the albumin by a binding side of the albumin, and it will be transported to the liver. In the liver, where the second process and the second station of the metabolism will happen. Here, the process of the conjugation of bilirubin, converting it from unconjugated to conjugated, or from the fat-soluble type to water-soluble type. In this form, it can be excreted by the GIT or by the urine. So the process will pass through two steps. The first is the uptake of the bilirubin by the Y and Z protein found on the surface of the liver. Then it will be carried out to the hepatocyte. Inside the hepatocyte, by the presence of the enzyme called uridine diphosphoglucuronidase transferase, or abbreviated to UDPGT, The bilirubin, it will be conjugated to one or more glucuronide molecules. So given the product of conjugated bilirubin. This conjugated bilirubin will be excreted with bile through the common bile duct, and it will come to the intestine. Here in the intestine, the conjugated bilirubin, it will be converted to the another form called urobilinogen. 90% of the urobilinogen will be converted to cercobilin, and this is given the normal and the usual color of the stool. And 10% will be reabsorbed of the urobilinogen, will be absorbed through the kidney or through the circulation to the kidney, where it will be converted to urobilin and excreted in the urine. And again, also it gives the a normal color of the urine. So here is the third and the fourth station of the metabolism of bilirubin. Now I think it's clear from its synthesis, its production to its excretion. Sometimes in the intestine of the small intestine of the infant, of the newborn, there will be a problem because there is absence of gut flora and there is a slow GI motility. It will be causes a stasis of the conjugated bilirubin. It will be there will be stasis in this. So by the presence of the enzyme called beta glucuronidase, there will be a or disconjugation that will be production of conjugated bilirubin again, which will be reabsorbed through the enterohepatic circulation and comes to the circulation. So what is the enterohepatic circulation? The enterohepatic circulation, that means the bile acid, the bilirubin, and sometimes even the drug or other materials pass it with the bile, through the common bile duct down to the intestine. Here there will be reabsorption of that product and going back to the portal circulation, but part of them will go to the systemic circulation. So this process play a role in the aggravation of the bilirubin in a newborn because of the activation of this enterohepatic circulation. This means reabsorption and re-entrance of the unconjugated bilirubin again into the circulation. Now, excess accumulation from the metabolism, it's clear now, excess accumulation of the bilirubin in the blood depends on two factors. Either the rate of the bilirubin increase or the rate of excretion is decreased. So the rate of bilirubin in the production or excretion. From that, there will be imbalance of the normal metabolism of the bilirubin. Now, what is the pathophysiology of neonatal jaundice? That means why the neonates have a special consideration or special characteristics that they will develop neonatal jaundice, or they are more susceptible to develop a high level of jaundice more than other age group. The first is more bilirubin produced, more than the other age group. Why? This is coming from much more hemolysis that happened in the bilirubin, in the neonates, and because of the short lifespan of the RBCs. This is the normal short lifespan in the neonates. You know, it may be extend to 120 days outside of the neonatal period. And this is, of course, in the term baby. In preterm baby, it may be just about 45 days for the RBC. Now, so we are talking about, this part of the metabolism. When there is more hemolysis, the more hemolysis comes from either intravascular, like what happened in diseases, or extravascular, like what happened in cephalohematoma. You remember from the last lecture, we talked about the significance if it is severe. Cephalohematoma may predispose to more hemolysis of a blood, extravascular. Now, the other contributing factor or the consideration is that the low capability of albumin to transport and conjugated bilirubin. Now, it's clear from the metabolism of The albumin is very essential to transport the unconjugated bilirubin to the liver. So in a newborn, there will be a condition called the acid intoxication. So an acid intoxication or less albumin in neonate will decrease its efficacy to transport the bilirubin. Now, the third consideration, now we are talking about this point of the metabolism where the unconjugated bilirubin plus albumin, here is the problem, or here is the consideration. Now, the third consideration is the low capability of the hepatocyte to uptake bilirubin. And this happened because of immaturity of the enzymatic process of the conjugation, because of less of the uptaking proteins, or the easily broken hepatic enzyme system. We are talking about the process of conjugation that happened in the liver. The fourth consideration is the high workload of the enterohepatic circulation. This happened because, as we say, because of less gut flora and because of low enzymatic activity in the intestine and the high level of bilirubin in meconium because of stasis of meconium. So we are talking about this part, and the conjugated bilirubin, we say it will be converted to the unconjugated bilirubin again, and it will be reabsorbed to the circulation. These are the special considerations making the neonates are more susceptible to develop neonatal jaundice. Now, what are the classifications of neonatal jaundice? We have to classify the neonatal jaundice. The classification will be on both according to the cause and according to biochemical aspects. So neonatal jaundice is classified into majorly or grossly to unconjugated or what's called indirect. That means the type of bilirubin is mainly, of course, it's mainly indirect or unconjugated bilirubin, and the other is conjugated or direct. The unconjugated jaundice or indirect jaundice, it will be subclassified into two groups. So it could be either physiologic or it could be pathologic. While the conjugated or the direct, it is always pathologic. There is no physiologic conjugated bilirubin or neonatal jaundice. I will start with physiologic jaundice because understanding what is physiologic, we will understand what is pathologic. Now, what are the contributing factors? Why the newborn are more susceptible to develop physiologic jaundice? Again, I will repeat it. It's because of relatively high RBC mass and short RBC lifespan, because the less activity of the glucuronidase transferase enzyme that's essential for the process of conjugation, because of the absence of the intestinal flora and the slow intestinal motility, sluggish bowel movement, and because the activation of the enterohepatic circulation of bilirubin in the first day of life, especially if the feeding of the life, it was unsatisfactory or it's inadequate. Now, what are the criteria of the physiologic jaundice? We have 4 criteria. And to say this baby has physiologic jaundice, this is meaning all these criteria should be present. Absence of one, making this is a pathologic jaundice. So what are these? Firstly, visible jaundice appearing after 24 hours of age. So any jaundice appear in the first 24 hours of age, this is absolutely pathologic. The second is the level of total serum bilirubin. It should be rise daily, but it's not more than 5 milligrams per deciliter. The peak bilirubin level occur at 3 to 5 days. This has happened in term baby and about 7 days in preterm. But the TSB level in its high peak level, it should be not more than 15 milligrams. So if the bilirubin level, it is more than 15 milligrams, whether in a preterm or term baby, this is of course out of the physiologic jaundice. And the other is the visible jaundice resolved by 1 week in the full term and by 2 weeks in the preterm babies. So any jaundice that is still persistent after this period, regarded as pathologic. All these criteria should be present to say this is physiologic jaundice. Now this diagram shows what I said before. So you can see here it starts after the first 24 hours of life, and it's peak in about 3 to 5 days in preterm and about 7 days in term baby, and it should be resolved during the first week of life and not more than 2 weeks and the maximum level should be less than 15 milligram per deciliter. And of course, the rate of the rising per day, it should be less than 5 milligram per deciliter. Now we will go to the pathologic jaundice. You know, the physiologic jaundice. So pathologic jaundice, you should suspect the pathologic jaundice in a newborn if absence of the previous criteria. We will repeat. Appears within the first 24 hours of age. It's absolutely pathologic. Increase more than 5 milligram per deciliter per day. The total serum bilirubin more than 15 milligram per deciliter. And jaundice persisting after 14 days of life, and this is called the prolonged jaundice. And presence of stool, clay color or white, and urine is dark yellow that make the napkin or the diapers become yellow. These are criteria of pathologic jaundice. But for pathologic jaundice, presence of one of these criteria is enough to say this is pathologic, not like the physiologic. In physiologic, all 4 criteria. But here, just one of these, it's enough to say this baby has a pathologic jaundice. You have to search for the cause of it, and you have to manage it. And I will add the bilirubin level. You know, bilirubin, it may be direct and indirect. So that's why when we call total serum bilirubin, we mean both. So if the direct bilirubin or direct fraction of the total serum bilirubin is more than 2 milligram per deciliter, or it's more than 20% of total serum bilirubin, this is, of course, making the diagnosis goes to the direct neonatal jaundice or conjugated, which is absolutely always it is pathologic. Now, I will go in the details of the pathologic unconjugated hyperbilirubinemia, or what you call it the indirect. And we will postpone the talk about the direct to the end of the lecture. Now, the pathologic unconjugated, it is grossly, or it can be grouped into 2 main categories. First is an increased production of bilirubin. More bilirubin produced more than the physiologic. Now you know the contributing factors in physiology. Here is out of the physiologic range. The second group of causes, it will be decreased conjugation of bilirubin. That means it may be with normal level of production, but there is a failure or impairment in the process of conjugation, so most of the now, so the TSB level is a reflection of the balance between these 2 processes. If all are balanced, the normal physiology will happen. Imbalance will cause the. Now we will go in details of the group of overproduction of bilirubin. It may be hemolytic causes. We say the hemolysis. And we have other group, which is non-hemolytic causes. If we talk about the hemolytic causes, so we have what's called the immune-mediated type. Here, the Coombs test is positive, or direct Coombs test, or what's called the direct agglutination test. And the example is the ABO incompatible to RH incompatible to Rh-isoimmunization. Or it may be non-immune mediated, like what happened in processes of RBCs membranopathy, like inherited spherocytosis or elliptocytosis, or maybe due to enzymopathy of the RBCs that happened like in the G6PD or pyruvate kinase deficiency, or it may be due to hemoglobinopathy like what happened in alpha thalassemia, not beta thalassemia, and the sickle cell anemia. Or sometimes the hemolysis comes because of the neonatal sepsis, because in neonatal sepsis, you know, there will be a disseminated intravascular coagulopathy, there will be more hemolysis of the RBCs, but of course will be not immune mediated. Non-hemolytic causes, this is meaning there is no over-hemolysis of RBC. So why the bilirubin produced? This may be due to extravascular hemorrhage, like what happened in the cephalohematoma or intracranial hemorrhage, and extensive bruising also may cause it birth trauma. Polycythemia. Polycythemia means high RBC mass, so it will be produced because short lifespan and will produce more bilirubin. The third is the exaggerated enterohepatic circulation, and we talk about this when there will be cleavage of the conjugated bilirubin in the inside of the intestine, and like what happened, this may be in functional ileus or in bowel obstruction happened in the newborn. This is more than the physiological, and maybe due to breastfeeding associated jaundice. And this is mean there is inadequate intake of breast milk, so causing exaggerated of the enterohepatic circulation. These are the group of non-hemolytic causes. These mean the bilirubin produced more than the normal. Now we will go to the other group, which is decreased rate of conjugation. That means the bilirubin produced with normal range, but the process of conjugation will be impaired. It may happen in hereditary disorder called the Crigler-Najjar syndrome, which is a rare disease and severe disease. It can be of both types. It may be of type 1, which is autosomal recessive inheritance, and here there will be a complete deficiency of the enzyme, which is the glucuronidtransferase or UDPGT, or we have type 2, where there is a partial deficiency of this enzyme, and the mode of inheritance is autosomal dominant. We have other genetic disorder called the Gilbert syndrome, which is common, more than the Crigler-Najjar, and it's milder, and its inheritance is autosomal dominant. And here, the normal level of the enzyme, but its activity is low. And it may be due to congenital hypothyroidism. You know, hypothyroidism, it will cause decreasing of all metabolism of the body. So one of the metabolism that affected is the process of conjugation. So this will lead to accumulation of more unconjugated bilirubin. I will talk in details about the ABO incompatibility or AB blood group incompatibility. So it is not as common, especially in the first pregnancy. The ABO incompatibility, it may happen when the mother will be O blood group and the baby is A or B, but it happened when the mother can be A blood group and the baby may be B, or the mother is B and the baby is A. But the mother type, of course, it will be O, as I said, and the baby will be A or B, or it will be of other blood group. Of course, we are talking about blood group, so both the baby and mother here are of the same Rh. Either they are the same Rh negative or Rh positive. And because of Rh positive is more in popularity in the population, so you can regard it as all of talking about the positive Rh. Now, this is just to remind you from physiology what we mean by the A, where the presence of the antigen of A and the antibody against B. While B, the opposite, in AB, there is antibodies, but they have two antigens, while in O, they have two antibodies against the A and B, and they have no antigen. So, ABO incompatible practice, it happened when the mother are O and the baby is A and B. Now, in that condition, the AB incompatibility, the hemolysis is usually mild, but it cannot be predicted. Why? Because of the variability of the amount of naturally occurring maternal anti-A or anti-B antibodies. We cannot predict this baby with O blood group mother, and he is A. He will suffer of severe hyperbilirubinemia or severe hemolysis or not, because this is a naturally occurring antibody. We cannot predict it. This is not like what happened in Rh-isoimmunization. Now, what is the percentage of the mother to be O blood group and the baby is A and B? It's about 20%. The mother O and the infant is A and B. Of those 20%, just about 33% will have a direct Coombs test positive. That's mean the evidence or the reflection of hemolysis. And about those, and those, 20% of those have positive direct Coombs test. Just 20% of them will require a high level of bilirubin and a clinical jaundice that require therapy. So that's why we say the hemolysis is usually mild. If we go to the other issue, which is the Rh-isoimmunization, in comparison with the ABO, It is less common, but it is more severe and more predictable than AB incompatibility. Why? Because, you know, the baby is Rh positive, the mother Rh negative. So if there is a fetal to maternal transfusion and mixing of blood, so there will be a production of antibody in the side the body of the abdomen, sorry, the mother, and it will be go back to the baby and causing hemolysis. So the severity, it increases with each immunized pregnancy. That's mean the first baby may be affected, maybe not, but the successive babies, it will be affected more because there is an accumulation of more antibodies against the body of the baby. So here, if to understand, if an Rh negative mother with Rh positive father are making a couple and the mother become pregnant, so if the baby is Rh positive, this will lead to the Rh antibodies. It will go inside, or there's RBC goes inside the circulation, maternal transfusion, and this will lead to production, or sorry, this will lead to production of the antibodies, and in successive pregnancies, these antibodies will invade the circulation of the new infant or new fetus and will cause hemolysis of its or of his blood. Now, the affected neonate are often anemic at birth because there is anemia, not just hemolysis, severe hemolysis. And the continued hemolysis may cause hyperbilirubinemia and more severe anemia. Now, the most severe form of Rh-isoimmunization, we call it the Erythroblastosis Fetalis. And Erythroblastosis Fetalis, which is the most severe form, it's characterized by life-threatening anemia, generalized edema, fetal or neonatal heart failure, and if there is no antenatal intervention appropriately, there will be fetal or neonatal death often results. So this picture shows an infant with hydrops fetalis. You can see the generalized edema of his body because of a severe hemolysis inside the uterus. What are the risk factors to developing severe indirect jaundice? Can we predict that this baby we are dealing with may have a severe indirect jaundice? Yes. This comes from the abbreviation of the letters of word jaundice. So if you have in family jaundice within the first start in the first 24 hours of life, we expect it will be severe. And if we have in the family history a sibling who has jaundice, if the baby has unrecognized hemolysis, like in hereditary disorder, spherocytosis, or G6PD, non-optimal sucking or feeding, these are signs of lethargy and poor feeding, signs of infection maybe, or the affection of the brain because of the bilirubin, deficiency of G6PD, infection, sepsis also has a high risk, and cephalohematoma or bruising because we say this will predispose more jaundice, and E, if they are of East Asian or North Indian, they have the incidence of jaundice in that races is more than other. Now, how we can approach to patient with unconjugated neonatal jaundice clinically? Firstly, we will start with taking history. And of course, we should firstly ask about the gestational age, the age of onset of jaundice and duration, because if the jaundice, as we said, in the first 24 hours, we say this is physiologic. If it is more than 14 days, it's also pathologic. So it's important to know the onset and the duration. History of lethargy, irritability, convulsion, posturing, and high-pitched cry, all these are signs of bilirubin toxicity. Feeding history, because the feeding may be affected because of the presence of toxicity or because of the sepsis. The antenatal history of APH, premature rupture of membrane, maternal DM, thyroid disorders. This may give an idea about the fetal-maternal transfusion or of the congenital infections or on the affection of the baby that may cause the baby at risk to develop jaundice. History of birth asphyxia and resuscitation. It's very important. This is regarded as risk factor. Family history of jaundice, very important, because this given a clue about the hereditary disorder. So if the family history, they have jaundice, anemia, splenectomy, metabolic disorder, all it's important if they have blood transfusion. Previous sibling history, if there is a neonatal death or morbidities in the family is also important. Now, the time of first stool passage or color of stool and frequency of stool, because we say it is important to differentiate if it is direct or indirect if the patient has a clay color stool. And of course, the urine color and the frequency is important. If we will go to, after finishing the history, we will go to the clinical assessment. This means the clinical examination. It's very important to check the color of the skin. But to check the color of the skin of a baby, it should be of the naked baby, on natural light, on the sunlight, and there is no yellow background because this will exaggerate the appearance of the jaundice, and with minimum blanching or pressure over a bony surface, because the bony surface is like in the shin of the tibia, it will be, or the sternum, it will be always yellow when you just press on it. So avoid to press. We use the nose or the chest in general or the abdomen. Then we have to determine the severity of the jaundice by the clinical assessment, and we have what's called the primary staging of jaundice. We have to assess if there is anemia, this means pallor, or there's a sign of dehydration, examine if there's hepatosplenomegaly, and do a complete neurological examination to exclude the signs of kernicterus, that means the bilirubin toxicity, and you have to look for extra vascular hemorrhage, like encephalohematoma or bruises, bulging of the anterior fontanelle. That means if there is a huge intracranial bleeding. If there is abdominal mass, it may be due to, as we say, hepatosplenomegaly, or it may be due to abdominal distension because of ascites that happened in hydrops fetalis or erythroblastosis fetalis. Now, if we take the primary stagings of jaundice in details, how we detect the staging of the jaundice? As you remember, we said that jaundice is visible newborn when its level is between 5 to 6 milligrams. You have to know that the distribution of bilirubin in the skin, it follows the arrangement of the cephalocaudal. So this means it starts from the face, from the head to the toes, go downward. So the primary staging, we divide the regions of the body into 5 regions, and in each region we can give an approximation of level of TSB according to the presence of the yellowish discoloration on that part of the body. Now, it's not enough to make a clinical or visual assessment of the bilirubin. We have to measure the bilirubin. But what are the indications of measuring the bilirubin by lab investigations? And what is the first measuring? We will start with what's called the Transcutaneous bilirubinometer. Here is useful adjunct to the TSB measure. You know the TSB measure, it needs a further or frequent blood sampling. This may cause infection, this may cause anemia, this is harmful for the baby. So we may avoid it by doing the transcutaneous by this device, as you see here on the forehead of the baby. And this gives a good correlation of the level of the bilirubin if it is less than 12. But when the level of the bilirubin is between 12 to 14 by the transcutaneous, so we have to do the TSB, which means the lab, the blood investigation, especially if it is more than the 14 milligram per deciliter. Now, of course, you saw this before, I think, if you have a relative, they have neonatal jaundice, and this is called the capillary heel stick or prick to take the sample doing the the total serum bilirubin level. What are the indications to do? If jaundice appear in the first 24 hours of life, because this is, and after the 24 hour, as you saw, if the visual assessment or the transcutaneous is at above 12 to 14, so we have TSB. Or if we are approaching the phototherapy range, we deciding to do the phototherapy or not, so you have to do the TSB. If we are not sure about the a visual assessment because of the surrounding, because of the way of measuring it. So it's better to do. And when you put the patient on phototherapy or under the phototherapy, so you have to check the TSB frequently and to see if there is a rebound increase in the bilirubin, like what happened in hemolytic jaundice, especially in the ABO incompatibility or Rh-isoimmunization. Now, after taking the TSB level, you have to classify or designate your patient into 4 or 5 zones. It may be of high-risk zone or low-risk zone, and we have the intermediate, and the intermediate, it will be divided into high intermediate or the low intermediate. How we can classify our patient to high or risk zone? This regarding on 2 parameters, the age in hours and the level of total serum bilirubin. This is very important because the guideline of management, whether phototherapy or the exchange transfusion, will depend on the risk designation. It means classification of baby into the presence of risk. You have to know the specific diagnosis of neonatal jaundice. We say the pathologic jaundice. Why this patient I deal with has jaundice? I should know the specific causes and this jaundice. So we will follow an algorithm to make or to reach the diagnosis of jaundice, specific diagnosis. Firstly, we will start with doing Coombs test positive, especially if the bilirubin level is more than 12 or it starts in the first 24 hours. So if the Coombs test is positive, this means we are in the immune-mediated hemolytic, like Rh-ABO. If it is negative, what we will do? If it is negative, so we will do a fractionation of bilirubin. Fractionation of bilirubin, that means you will fractionate the total serum bilirubin into direct and indirect. So if you found the total serum, the direct bilirubin is more than 20% of the TSB or more than 2 milligram per deciliter, as we say, so you will go to the group of direct jaundice. But if it is less than this, less than 20% or less than 2 milligrams, so you are in the field of indirect. Now you will do hematocrit. You will check the PCV of the blood. If it is high, so this is mean polycythemia, and you reach to the diagnosis, the high RBC mass. But if it is normal or low, so you should think the cause is hemolytic anemia, but of non-immune mediated, like RBC morphology, we say spherocytosis, or the G6PD. So here you will check for the reticulocyte count, which is a reflection of the reticulocyte count, which is a reflection of the hemolysis, and you will check the enzyme, and you will check the blood film. So if they are abnormal, the cause may be spherocytosis, elliptocytosis, G6PD, and if it is normal, the RBC morphology is normal, the reticulocyte count is normal, the level of G6PD is normal. So you think of an enclosed hemorrhage, like in cephalohematoma, or you think of causes of decreased conjugation of bilirubin. By following this algorithm, you can reach to the diagnosis specifically of the jaundice. Now we will go to the treatment of indirect jaundice. Before reaching to diagnosis of jaundice, you have to treat it because it is risky if you leave without a treatment. What are the aims of treatment of jaundice? Of course, you have to prevent the hyperbilirubinemia by encouraging early feeding and adequate hydration. This is the usual recommendation of the baby when we discharge him, the well baby, for his family. We encourage them to increase the feeding and adequate hydration. This will lead to a restful metabolism of bilirubin. And the second is to reduce the bilirubin level if it is high to prevent the bilirubin toxicity. Which tools? We have two: phototherapy and exchange transfusion. Now we will start with phototherapy, and I think you know the phototherapy and you see patients under phototherapy in your family or in your life as a medical student. Now, phototherapy, it remains the mainstay in treatment of neonatal hyperbilirubinemia. How the phototherapy acts? The phototherapy, it will make a reconfiguration or reconstruction of the bilirubin with the process called photooxidation or photoisomerization and structural isomerization. This will converting the insoluble or the fat-soluble bilirubin into water-soluble that can be easily excreted in the urine and in the bile without the process of conjugation. So you will bypass the process of conjugation by doing the phototherapy. Now, it is relatively non-invasive and it's safe process. And we have two types of phototherapy. Start with is the conventional phototherapy and we phototherapy. We will know the differences between. So the process of structural or configurational isomerization or the photooxidation or photoisomerization, it will that we put the baby under the normal light in home. It may reduce the jaundice. And the answer is no, because the phototherapy used in hospitals, it has a special wavelength, and it is a blue-green spectrum, and it will absorb by the unconjugated bilirubin in the skin, while the normal light is not. And the minimum effective light dose is about 10 to 14 microwatt per centimeter radiance. This is in conventional PT, and it will be maybe the double radiance in the intensive phototherapy. Now, this is the conventional phototherapy, the baby inside. This is the intensive phototherapy. The radiance will be increasing more than the normal, but the wavelength is the normal, or is the same, sorry. Now, the light source will be above the baby and will be under it. So the exposure will be about 360 degrees, and this will lead, and of course we can reduce the distance between the light source and the baby to yield a more radiance. This is the therapy, and the intensive phototherapy, I think you see it in our hospital. We put the baby inside it, and you can see here the light is around it when the distance is short between them, and giving the 360 degree of light exposure. Now, what is the technique? In conventional phototherapy, the distance is about 30 to 45, but it will be the half in intensive phototherapy. The room of temperature, it should be about 26 to 28 to prevent the hypothermia. And we should expose the maximum surface area of the body of the baby, remove all clothes, of course, just the diapers, we should cover it with diaper. We should apply a small eye patches to prevent the retinal or the corneal injury, corneal ulcer, and from the exposure to light. And we should ensure the adequate nutrition and hydration to prevent the dehydration. And we should minimize the interruption during the feeding or procedures because it needs time to act to be absorbed by bilirubin for the photo, and there is no need to supplement the breastfed baby with any other feed or fluid during PT because the breastfeeding is enough. And we should monitor the TSB every 12 or 24 hours. We should watch for rebound bilirubin clinically if we found the patient has increasing in intensity of the jaundice. Here is the guidelines of which baby is eligible to start phototherapy. This is done by the American Academy of Pediatrics, and this takes the parameters of the total serum bilirubin and the age in hours or in days, and of course we divide the patients into three, a group of high risk, low risk, and medium risk. And what is, how we can judge this patient is high risk or low? This is according to the presence of the risk factors. This normogram or this guideline can be applied since the age of 35 weeks or more, but not for preterm babies. Now, the intensive phototherapy, because it acts more intensively, so it will decrease more the bilirubin level in the first 24 hours. Of course, this process has side effects. It may increase the insensible water loss, and lead to dehydration. So we have to encourage the feeding, and of course we have to encourage the feeding and may give IV fluid. The loose green stools that happen because of the light exposure. The skin rash, which may happen as a photosensitivity, but it's not harmful, and we can or we should continue on the management. Bronze baby syndrome. This is if the baby has a direct jaundice and we put him under the phototherapy. Here it should stop the phototherapy unless if it is necessary to prevent the high level from causing neurotoxicity. Hypo or hypothermia because of exposure to the surrounding. Now we will go to the other part of management, which is the exchange transfusion. The exchange transfusion is reserved for the most severe forms of neonatal hyperbilirubinemia. Those didn't get benefit from phototherapy, or this is with high level that should start the exchange before doing the phototherapy. So what are the indications to start to do the exchange transfusion? Extreme hyperbilirubinemia, secondary to Rh-isoimmunization or IV incompatibility. This is mean causing ongoing hemolysis. Any infant with TSB above 30 milligrams. This is extremely high level causing brain toxicity regardless of the cause. Infants with signs of encephalopathy, you should not delay. And intensive phototherapy, you start intensive phototherapy, but should not lower the TSB level by about 0.5 milligram per deciliter per hour after 4 hours of initiation of the therapy. Sometimes we may start doing exchange transfusion immediately after birth or early after birth. So what are the indications to do this? If we have the cord hemoglobin less than 11 grams per deciliter, this is regarded as severe anemia. The elevated cord bilirubin more than 4.5 milligram. This means before the bilirubin becoming visible. And rapid rate of increase of TSB is more than 1 milligram per deciliter of hour, so you cannot leave it because in just a few hours it will be reaching the extreme levels. And of course, if you start intensive phototherapy for 4 hours and there is no decrease in the rate you see here. Now, what is the exchange transfusion? It's called the double volume. The normal blood volume in a neonate is about 85 ml per kg. So you have to exchange of a double volume, about 160 to 180. This is required. The exchange transfusion, the TSB acutely, it means immediately after the exchange will decrease by about 50%. And it removes about 80% of sensitized or abnormal RBCs and offending antibodies. So the ongoing hemolysis is decreased. So it will prevent further elevation or further hemolysis of the baby blood. The syringe here, we use a syringe called of a three-way valve. This can, with swinging, we can move it, sliding it from the donor blood to the umbilical catheter. Here it comes inside the umbilicus of the baby and to the outlet of waste product. Actually, we have to see, or we have to attain a real exchange transfusion to see the procedure properly. Now, what the blood we should prepare for exchange? In this table, you can see what is the type you should choose in each condition. Now, the preferred blood should be put in a preservative called the citrate phosphate dextrose. This is an anticoagulant. And the blood should be less than 72 hours because this will ensure the pH of the blood between 7 to 7.2. Because the citrate that found here later on will cause metabolize and cause alkalosis. Choose a blood of 7 to 7.2. You will avoid the late metabolic alkalosis. Now this is the exchange transfusion. You can see here the catheter inside the umbilicus, and this is the three-way valve or the three-way syringe. This is going to the coming from blood bag, and it's going to the waist, and we can swing between them to choose which blood would go in or inside of the body. Now, again, we have a guideline put by the American Academy of Pediatrics to choose which patient is eligible or should undergo the process of exchange transfusion. And we start from the age of 35 and more, 35 gestation week. The complications, we have a lot of complications in the exchange transfusion. We say even it may cause a sudden death, can happen in any infant. So the mortality in the patient with doing for the exchange transfusion may be 1 to 5%, and it's the greatest in the smallest, most immature and unstable infants. Now, we talk about the phototherapy and the exchange transfusion, and if the gestational age of the patient is 35 weeks and more. So what about the preterm baby? Here we have the consideration according to the birth weight, not to the gestational age, if they are less than 35 weeks. And this is the maximum level of uncomplicated or complicated courses. And we should start phototherapy if the level reached to 50 or 70% of this maximum level. So if I have a newborn, which weight is 1,000 grams, and he is uncomplicated, and his level is 12 to 14%, this is the highest. So if the level, the real level of the baby, TSB, I mean, it is between 6 to 7 or to 8, I should start phototherapy because this represents 50 to 70% of this. So the complications, we say complicated, non-complicated, these are the complications, and we put the perinatal aspects here on the top of the list. We have other modalities to treat neonatal jaundice other than the exchange and phototherapy, like the intravenous immunoglobulin. And this is recommended by the American Academy of Pediatrics in isoimmune hemolytic disease if the TSB are increased despite the phototherapy, or if the baby is within 2 to 3 milligram of level of exchange level. And it may be given once and may be repeated if necessary. Also, we can use albumin. You know the effect or the importance of albumin. So if the patient has level serum albumin is very low, we can give albumin. Now we will go to the bilirubin toxicity because our concern is to prevent this toxicity. You know, the unconjugated bilirubin anion is the agent of bilirubin toxicity. And this will attach to the phospholipid or the ganglioside and the neuronal plasma and causing the injury and making the allowance or the permission for more anion to enter to the neuron. But this process is prevented by what is called the blood-brain barrier. Here is the normal capillary. This is the normal capillary, but this is a brain capillary. In the brain capillary, we have what's called, if you see the boundaries or the barriers, this is called the blood-brain barrier. This acts to prevent the passing of the unconjugated bilirubin or free bilirubin inside the cell, inside the neurons. So any newborns, we cannot, or in patients with a clinical illness, acute illness, we cannot assess the integrity of this barrier. We cannot say this baby has an intact barrier and he is protected from passing of bilirubin from the lumen of the capillary to the brain cell. So this is the issue. Yes, we have a blood-brain barrier, but we cannot predict its intact way to prevent the process. So what is the kernicterus? It is the pathologic finding of staining of basal ganglia and the brainstem nuclei. And again, it is the clinical syndrome of chronic bilirubin or brain injury due to hyperbilirubinemia. So when we say this patient has kernicterus, we means the clinical syndrome of a chronic brain injury. While we have what's called the acute bilirubin encephalopathy. Here is the sign and symptoms of the brain injury in the neonatal period. The risk to develop the kernicterus and the acute bilirubin toxicity is about the duration, about the concentration, associated illness, acidosis, because this affects the intact matter of the manner of the blood-brain barrier, the concentration of competing anions, so that's triaxone and sulfamethoxazole is contraindicated to neonatal period because it competes with the binding proteins, and the prematurity, because the prematurity means the integrity of blood-brain, it's affected or it's low. Now, we should classify, as what we do in birth asphyxia, classify the affection of the brain, the neurotoxicity, into score called the bind, or its mean bilirubin-induced neurological deficit. And we can assess the encephalopathy in that baby if it is according to these criteria, according to the score and parameters, if it is reversible or irreversible. This patient has what's called the choreoathetoid. Here's the arching of the back, and you can see here the molding, and you can see the exchange done for him, but unfortunately this patient has the effect of acute bilirubin toxicity, and of course he will develop the kernicterus later on. So chronic bilirubin encephalopathy, it is irreversible brain damage, and it is characterized by choreoathetoid cerebral palsy, like what you see here, and gaze abnormalities, auditory disturbance, sensory neural deafness, and also the decidual teeth will be affected. How we can diagnose the kernicterus? Of course, clinically, of course, radiologic testing, and the brain MRI is diagnostic. Here you can see the staining of the hyperintense area of the basal ganglia and the globus pallidus in MRI because of the staining of bilirubin. And this is the post-mortem show the staining of the basal ganglia because of the bilirubin accumulation. Now we reach to the end of the lecture. If you don't have more minutes to talk about the direct jaundice. Direct jaundice, it's mainly the TSB is more than 2 milligram, or if it is more than 20% of the total, and it's we say always pathologic. We have a list of causes, maybe hepatic biliary, intrahepatic, hepatocellular, or other causes. And the workup, it involves a lot of lab investigations and imaging studies, because it may be an anatomical problem, and always the management may be medical or pharmaceutical or maybe surgery. Now we reach to the end of our lecture. Thank you for your listening. If you have a question, you can send it